What instruments you have to use for these aims? First of all, use the explorer to check for smoothness. You need or you have to use the probe to check for appropriate depth and width. The final dimensions of the preparation are determined by the extent of the carious lesion or existing of faulty restoration. The next, what you have to do, it's understand what position have to have the dental mirror, and for what aims this instrument you need. Position of the mirror to achieve indirect visions of the preparation. Place a wet in between the adjacent teeth to separate the contact areas. We continue to discuss the main steps of preparation, and you can see the photo with the cleaning and drying the preparation using the air water storage, and examine the preparation and evaluate the proper dimensions. Dental instruments. I told you about the dental probe and the dental explorer. It's often the same instruments. Dental mirror. You can see high speed and slow speed. Or explorer, you can see too. It's a specific dental probe named Dental Explorer. Dental forceps or tweezers, and the instrument for their obturation or filling dental cavity or carious cavity after preparation. Don't forget, always, please don't forget to play the matrix for separation, proximal intact proximal surfaces, because, for example, if you see cavitation on both proximal surfaces in adjacent teeth, you don't have to put the matrix into proximal space. But if you see that one proximal adjacent surface is intact without caries, without peeling, and without any, for example, non-carious lesions, you always have to put the matrix for protection this intact or healthy tooth surface. What about the main dental instruments, rotary dental instruments? It's a burrs. You can see on this slide the main types of dental burrs for preparation all classes of dental cavities or carious cavities. There are photo A. It's a very small diameter flame bore used for conservative opening of suspected grooves. The next B, photo B, it's a cylindric bore with rounded head used for most class 1 and 2 cavity preparation. The next C, bore C, it's a tungsten carbide rose head bore used to remove infected dentine. Please put your attention that carbide burrs using only for dentine preparation, not for enamel preparation. It's wrong. Carbide bore, it's wrong bore for dentine preparation. Because remember once more, please, the structure of enamel and the structure of dentine, and try to understand this carbide bore can't with carbide bore, you can't prepare the enamel structures because it's a very hard tissue without visual even under microscopic investigation, organic compounds. It's a very hard with the highest density tissue, means enamel. And dentine is another type of tissue. It's collagen fibers. Dentine includes collagen fibers, and dentine has the lowest level of non-organic compounds, and dentine partially mineralized. And for preparation of dentine exist these special types of bores. Carbide bores. And the next type, you can see photo D. Please put your intention of to this bore. It's end cutting bore used to define and finish a cervical step in class 2 preparation. What that means, I'll show you later, little later. You can see that end cutting bore only has only cut availability only on its end. The walls of this bore can't or don't has cut availability. The next type, it's a fine-grained flame bore used to finish class 2 box walls. And the last type of bore, it's Arkansas stone used to smooth the cavity margin. In the last step or last stage of cavity preparation. This or smoothing the cavity margin improves adhesion of dental materials. Chemical adhesion, first of all, or mechanical adhesion, too. On this slide, you can see class 1 standard form after classical preparation. Depending on the zones of demineralization. The first variant, you can see the preparation, the form of the cavity after preparation, the first class. And you can understand that all fissures and pits was involved by demineralization. The next example shows that demineralization was affect only central fissures or central zone of occlusal surfaces. And the last example shows that carious affecting or demineralization was on the points. What on the different points on the central zones on the occlusal surfaces, occlusal surface. It is different. It's a widespread. Three main examples of forms after preparation. The first class. It's simple. All dentists know that the first class of dental cavities, it's a simple class because the dentist can see all parts of cavity and the cavity too during the preparation, after preparation, and during the filling without additional instruments. Or maybe if you sit behind the patient, you can use or you have to use the dental mirror for upper molars, for observation of upper molars. But there are lower molars and premolars too, you can see without additional instruments, without using the dental mirror, for example. It's a direct vision of these cavities. More difficult a class for visualization and for preparation, it's a class 2. Very interesting class for treatment, but you have to know what you have to do and it will be simple for you. Outline form for the second class means extent of preparation on tooth surface. Classic preparation are typically larger than comparable composite preparation due to material requirement, basic principle of preparation of carious cavity, second class. Please put your attention on the screen on the slide. You can see the form of carious cavity, second class, after preparation. This form you need to use this form of preparation for the filling, for the quality filling. Only defective pits and fissures included. This is for the occlusal surfaces. Remember, please, that carious lesion or cavitation by classification localized on the proximal surface. These caries can affect a proximal surface, for example, only medial, or for example, only distal, or for example, it can be both surfaces, mesial approximal and distal approximal. The next equipment, all margins on down to structure and marginal right conserved. By Black's classical principles of preparation, you have to use prevention preparation, and you have to care, or you can't affect by both during the preparation the cuspids. The cuspids, because it's immune zones with the enamel, with the prismatic enamel, and on these immune zones, by Black's investigation, the widest layer of enamel. And all dentists have to care about these zones of each tooth. Retention, what that mean? Retention form, shape, and configuration of the tooth preparation, and resist their displacement or removal of restoration from their preparation under lifting and tipping masticatory forces. It's very difficult, and it's very difficult to form this form after preparation for restoring their tooth function. Because the main functions for their premolars and molars, it's a chewing, and during the chewing to form a special food form for their next layers, or for the next parts of the digestive system, digestive system. The next type, or the next stage, outline form, or the next equipment after outline form retention form, is a resistant form. Internal form of tooth preparation that allows restoration to resist forces of mastication. You can see the form. It's from the occlusal surface. The next part of this cavity after preparation, it's a form of the cavity on the approximal surface. And you can see the structure of the cavity after preparation. First of all, it's adequate depth, lower than 1.5 millimeter or 0.5 millimeter interdentine, because often the cavity on the occlusal surface, if we talked about the second class, it's additional cavity, because the main cavity situated on the approximal surfaces, because tooth decay are situated on this surface, on the approximal surfaces. And this is cavity, or it's an access cavity for the access to the main carious cavity. And often the additional cavity which you form during the access to the basic or main cavity, situated on the intact or healthy surface, healthy occlusal surface. Occlusally divergent proximal walls you have to form. Pulpal floor for the cavities class 2 has difficult configurations. The pulpal floor begins on the occlusal surface and ends on the approximal, for example, mesial surface. It's a difficult form, difficult pulpal floor. The main requirement for formation, the pulpal floor, it's parallel to occlusal surface or parallel to mesial surface, because you remember that the pulpal chamber has the same form that teeth crown and teeth roots. Rounded axial pulpal line angle for the best feeling in the future, and parallel to the pulp chamber. Pulpal floor of the all cavities after preparation have to be parallel the pulp chamber. The next requirement is convenience form of tooth preparation that allows for physical and visual accessibility to preparation. It's occlusal surface. You can see it's smooth 1 or 1.5 millimeter. You can see this size. Proximal contact open with less than 0.5 millimeter proximal clearance. It's a facial part or facial edge, gingival wall. Gingival wall always have to be parallel to gingival margin. And lingual part or lingual wall of dental or carious cavity after preparation or after formation. Some words about preparation in the incisor gingivally, mesial distal and facial walls. Extend the preparation incisor gingivally and mesial distally. Facial walls is at least 90% relative to the axial walls. Leave a small enamel shell interproximally. Break the enamel shell with a band instrument, and extension should remove the carious lesion or existing faulty restoration. Hand additional hand instruments that you can use. It's enamel hatchet and enamel hole. Use it's a little recommendation. Use the probe to check for appropriate dimensions. Incisor gingival length 2 or 2.5 millimeters, no greater than 3 millimeters, depending on the length of the contact. Gingival floor, white 1, gingival floor, I show you this gingival floor or gingival wall. Gingival wall white 1 from 1 to 1.25 millimeter. Check the final preparation dimension that are determined by the extent of the carious lesion or existing faulty restoration, and check for and remove remaining carious. The next features that we will discuss, it's a class 3 standard preparation. Class 3 cavities, it's a simple cavities too. More simply than, for example, cavities class 2. These cavities localized on the proximal surfaces without involving their incisal margin or without involving their incisal edges, nasal and distal. Incisal line will not involve when you diagnose this when you make the diagnosis and when you make the decision that you can that you see the cavities class 3. Excess, indirect excess using two. If the adjacent tooth by different reasons disappeared. For example, there's a tooth extraction, or for example, it may be physiological changes when the primary teeth change to the permanent teeth. You can provide the direct access from the proximal surfaces. But if the adjacent tooth appear, you can't provide the direct access, and you have to know how you can provide a direct access. The shape of the form, or the shape of the cavity class 3 after preparation, you can see on this scheme with the main with the main structures of this cavity and the main walls. It's a dental or cavity floor parallel to the pulp. It's you see the proximal surface. This cavity after preparation, cavity class 3 after preparation, always has gingival wall parallel to the gingival margin. Always have lingual or lingual or palatal wall, facial wall, and the floor, pulpal floor or axial wall. The scheme and the main requirements you can see on the slide on this photo too. This is the indirect access, which can formed only on the lingual or palatal surfaces, because aesthetic preparation, it's the main equipment for treatment the dental caries too. Function and aesthetic, and on the first place, this aesthetic preparation. You can't form indirect access when you want to provide preparation the class 3 on the labial surface. Return to the scheme. Put your attention on this scheme. Gingival contact broken by less than 1 millimeter. Facial depth, preserve facial contact. And remember, please, that you have to put the metrics for separation, the intact surface. For example, on this photo, you see intact surface of adjacent tooth, and you see the anterior axis to the proximal dental or carious cavity. All margins on sound tooth structures. Circumferential 0.25 millimeter from 0.25 millimeters to 0.5 millimeters bevel. Gingival floor wide 1 millimeter. It's a gingival floor. You can see gingival floor or gingival wall always parallel to the gingival margin. Gingival floor wide from 1 millimeter to 1.25 millimeters. Incisor gingival length less than 3 millimeters, and incisor floor wide from 1.25 millimeter to 1.5 millimeter have to be. Axis for remaining carious using the explorer or spoon excavator. Remove remaining carious to structure using the largest round bore that fits into the preparation with the rotary instrument, slow speed or carbide, or using the carbide bore or a spoon excavator. Let me to return the instrument, the main dental instruments. And you can see the spoon excavator. Very useful instrument for the preparation, for example, the axial floor or the pulpal floor, the pulpal walls of all cavities, and especially when the cavity lesion is depth or moderate cavity lesion. Class 3 standard preparation, direct division or direct access. When you see the dental or carious lesion on the proximal surface, but you understand that you can provide the direct access, you will do it without isolation of the proximal surface on the adjacent tooth. You can see this example on the photos on your screen. Carious lesion, class 3, without involving the incisal margin and incisal edges, distal and mesial, and you can see the direct access. This is cavity during preparation, direct access, and the last photo shows us how this cavity after preparation can form gingival wall parallel to the gingival region. This is, you can see the elevation with a rubber dam. Under this rubber dam, it's situated the gingival margin or gingival. A gingival wall, labial wall, or frontal fascial wall. It's an incisor wall parallel to the incisal margin, and the palatal wall because this is upper first incisor. The next, it's a class 4 standard preparation. On the slide, you see the main structural compounds, components of cavity class 4 after preparation. You remember that class 4 situated on the approximal surface and involved incisal part or incisal margin. This is a proximal part of the cavity. I show you this part. And the next half of this cavity situated on the incisal margin. It's not a simple full cavity. This is two cavities after preparation. The one cavity situated on the incisal part, the next cavity situated on the approximal part. We will start to discuss approximal cavity and its structural compounds. It's a gingival wall, gingival margin, gingival wall, always parallel to gingival margin, axial wall or pulpal floor, always parallel to the pulp chamber, and fascial wall situated near the fascial or labial surface. Lingual wall situated begins to the on the approximal surface and ends on the incisal line. Long lingual wall and pulpal floor on the incisal line, always parallel to the pulp chamber. It's very important to understand it. It's very important to remember because it can be it can lead not parallel pulpal floor after preparation can lead to the different complications, such as perforation the pulp chamber. And complication in this case will be inflammatory process in the pulp chamber in the pulp. It's very bad for the tooth, for the patient's health, and for the dentist too, because it will be iatrogenic complication. Yes, you want to ask something?
No, I just said it would be a pulpitis. Then you have to do the treatments outdoor.
Yes, pulpitis, yes, it's a diagnosis, and inflammation in the pulp chamber It's a pathogenesis.
Okay.
Yes, pulpitis. It's a very it's a very hard complication for the uh, teeth or tooth availability, because the pulp has many functions. For example, trophic function, defensive function, barrier function, and without pulp or with pulp involving the teeth can't have its function, its normal function, because due to this, you have to remember about the principles and the requirements for the formation of the pulpal floors always parallel the pulp chamber. Oh, sorry. I forgot to tell you about the nasal wall. It's very necessary wall to the next the future feeling. And this formation of these compounds of the cavities after preparation necessary, and these requirements not depend on their filling materials or type of filling materials. This is structural compounds after preparation, class 4 carious cavity have to be always class 2 class 5 preparation. It's a cervical caries or a cervical caries lesion. All teeth can be all teeth and all surfaces except occlusal surface and incisal margin or incisal surface can be involved by dental caries class 5. You can see on the slide the same principles of preparation you have to provide during the preparation. You can see on the slide the shape of cavity after preparation. This is the widespread shapes depends on the carious localization, carious class 5 localization. You can see that these cavities after preparation has the dent, the gingival wall, 2 approximal walls, and the wall incisal. It's for example, the first picture shows you the little zone of carious lesion. The next picture shows you the big zone, large zone of carious lesion. But the same compound, the same structural compounds, these cavities have to have. the same structural compounds such as class 4, class 2, and other. First of all, before we start to discuss characteristics of dental materials, some words about special cavity preparation techniques. You often will use their classic preparation techniques. It's very it's very difficult, but on the other hand, it's a very simple principles and requirement of preparation. But in some cases of dental caries lesions, you can use alternative techniques for preparation or special cavity techniques, preparation techniques. For example, due to appearance of contemporary dental materials such as photopolymers, for example, with chemical adhesion, or for example, glass ionomer cements with chemical adhesion to the dental tissue. You can use preparation techniques with less preparation of the hard tissue. For example, it's a minimal cavity preparation designs. Modern dentistry is based on advance in science. Modern dentistry means the minimal invasive preparation. Minimal invasive means hard tissue preparation. During the past few decades, practitioners and scientific developments in cariology, dental materials, and diagnostic systems have changed dentistry's approach to diagnosis and management of dental caries. With the development of bonding, adhesive and fluoride releasing restorative materials. I told you about these materials. It's photopolymers, glass ionomer cements. The concept of cavity and tooth preparation is undergoing revolutionary changes. In this procedure, retention has not been given much importance. Retention has not been given much importance, but only retention. All structural compounds and all walls, which we discussed earlier, have to be always. This conservative approach minimizes the tooth loss. It's true, it's a fact. And this is special cavity preparation techniques can be used only in condition the early diagnostic of carious lesion. Detection of the carious lesion, clinical informations after clinical investigation and radiographs are usually used to make. Other diagnostic tools are emerging Some methods are better for detecting occlusal caries, fissures caries, for example, while others are better for detecting proximal or smooth surface lesions. For example, you can use quantitative laser fluorescence, um, optical coherence tomography, electrical conductance methods, and tuned aperture computed tomography, for example, minimum surgical intervention of cavitated lesions. MID utilize technique and materials to access carriers. It cannot be remineralized and to restore the tooth with minimal loss of healthy structure. Extension for prevention is over. And new preparation techniques, air abrasion, hydroabrasion, laser, and ultrasonic without preparation with the burrs, without classical preparation with the burrs. Only in condition if the carious lesion is not depth. Several II.2 preparation and restorative techniques have been advocated. Um, Preservation of natural tooth structure should be guiding factors for the smallest as well as the largest cavity. Cavity preparation, design, and restorative material selection depend on the occlusal load and wear factors. Tunnel techniques, proximal only box, slot, abrasion, laser, slow accessing the caries dentine from the occlusal surface, while preserving the marginal right or marginal margin. Slow susceptibility caries index. Box only proximal class 2 cavity preparation, tunnel preparation, removing the marginal edge, but not including the occlusal pits and fissures if carious removal in these areas is not necessary. Only a small proximal box. Slot preparation, I showed you this slot preparation on the example on preparation class 1. Slot or point preparation, horizontal slot for contact point areas. If a decay removal and tooth preparation tool that is often used in place of the traditional dental drill, this innovative system means air or hydroabrasion allows to conserve more natural tooth structures and to reduce the risk of enamel microfracturing. Because the equipment doesn't produce vibration or heat, patients require little or no anesthetic. It's a very important part of the dental treatment. They all work essentially by blowing aluminum oxide, silicon powder using compressed air, though tips. The hydroabrasion unit sprays conical jet of warm water around the abrasive stream to capture virtually all dust. The warm water, which further improves patient comfort, starts and stops instantly with air abrasive flow. Laser are less invasive in patient treatment than a high-speed handpiece. It prevents surface and pulpal temperature rise, tissue cracking, and unnecessary removal of healthy surrounding tissue during cavity preparation. Unlike the regular turbine drills, Ultrasonic cavity preparation means dental treatment of individual teeth, preserve the tooth substance, and protect adjacent teeth. Development of new dental restorative materials and instrument leads to the naturally or leads to the conserving the naturally tooth structures. What about the dental materials? The main or the basic characteristics of dental materials, it's that these materials must not be poisonous or harmful to the body. Dental materials must not be harmful or irritating to the tissue of the oral cavity. Um, must help to protect the tooth and oral tissue of the oral cavity, must resemble the natural dentition as closely as possible so as to be aesthetically pleasant. It is necessary requirement for all dental restorative materials, for contemporary dental restorative materials. And dental materials must be easily formed and placed in the mouth to restore natural contours and must conform their and function despite limited access, wet conditions, and poor visibility. Properties of dental materials. Property description, mechanical properties, beating and chewing in the posterior area and of the mouth. Examples include force, which is the push or pull on meta stress reaction within the material that can cause distortion and strain, which in many changes produced within the material as a result of stress, pressure stress. Thermal change, temperature change in the mouth, which can cause dental materials to contract and expand. Electrical, a galvanic current that can take place with the condition of metals interacting with polymer. Its relativity only the amalgam or amalgam dental material. A corrosive reaction within a metal when it comes into contact with corrosive products. Certain foods and beverages can corrode a discolor material. Solubility, the degree to which a substance will dissolve in a given amount of a wet environment of oral cavity due to existing the saliva. Application, a material must have specific steps in the application process. There are 4 steps in this process include the flow of materials retention and engagement between the dental materials and the tooth, and the carrying of the material. The main types of dental materials. It's a bases and liners. It can be calcium hydroxide liners, zinc oxide, eugenol, zinc phosphide, glass ionomer cement. Cavity varnishes and dentin bonding agents. It's not the filling materials for the permanent plombs or for the permanent filling. It is the first layer which covered the dental or pulpal floor or axial walls. Restorative materials, it's amalgams or resin-based composite. Resin-based composite is a chemically polymerized resin-based composite. Visible light polymerized resin-based composite. Resin-based composite wear, marginal indentation and formulation. Except amalgams and resin-based composite existing the universal dental material with carious protective properties. This is glass ionomer cement. These glass ionomer cements very useful for the dental tissues because this glass ionomer cement have the two main properties. It's chemical adhesion, or it's a chemical adhesive materials, and it's fluoride or compounds in these materials which provide on the chemical adhesion and chemical communications between the material and hard tissues of the tooth. And on the other hand, these fluoride compounds leads to the carious protective effect. Glass ionomer cements divided to anterior restoration cements, posterior restoration cements, compomers, and cements, simple cements. Amalgam, gold amalgam, first of all, it's a very widespread materials on the many countries. Composition of amalgam alloy powder, it's a silver, gives the strength, tin gives the workability and strength, copper gives its strength and low corrosion, and zinc suppresses oxidation. Preparing the amalgam has very simple character for today. It's a contemporary amalgam capsule. Amalgam is supplied by the manufacturer is a sealed single-use capsule with the proper ratio of alloy powder in one side of the capsule and make mercury on the other side, separated by a thin membrane. Capsules are available in 600 milligrams of alloy, which is the appropriate amount of materials for small or single surface restoration, or 800 milligrams of alloy, which is selected for a multi-surface restoration or big depth cavity restoration. Amalgam can't to use on the frontal teeth. You can't use the amalgam restoration when you want to fill in carious cavity class 4, class 5-2. And composition of composite resins. I'll tell you about amalgam, glass ionomer cement, amalgams, and composite resins because it's widespread materials in the dental practice. Composite resins includes properties such as the highest aesthetic characteristics, the highest mechanical characteristics, and the higher levels of adhesion in comparison to amalgam, for example. But not highest level of adhesion because exist the glass ionomer cements with chemical adhesion to the hard dental tissues. Composition of composite resins, chemical curing and light curing types of these materials. It's a resin matrix, also known as bis-GMA or bisphenol glycidyl. Fluid-like materials used to make synthetic resin, inorganic fillers, quartz, glass, silica, and colorants, which add the strength and characteristics necessary for restorative materials, coupling agents, straightness and chemically bonds to the filler to the resin matrix, and pigments give it color because you can provide imitation of enamel and of dentine relatively the natural these structures. And the last issue which we will discuss, it's obligatory equipment or necessary for the dental restoration and aesthetic restoration too. It is to follow the natural shape of each surface of each teeth. There are two examples on your screen. Aesthetical and functional restoration on the front teeth. It's first incisor or central incisor before restoration and after restoration, and aesthetical and functional restoration of molar. It's a first molar. You can see the stages: tooth preparation or cavity preparation, and with formation the dental cavity, the stages of filling, and you can see the result: function and aesthetic, or aesthetic and function, as you wish, but this is two necessary conditions for the restoration of each tooth after carious lesion. Thank you for attention.
Thank you so much. Thank you so much.
Thank you so much. Have a nice day.
You
Goodbye.
too. Be safe. Do побачення.
До побачення.